Hi guys, Dr. Douglas Gillard here once again. We're going to talk about something called recombinant human bone morphogenetic protein 2. Let's just call it BMP for short. Now, why in the world would we want to even listen to something like this? Because all of you people contemplating any type of fusion, there's a chance that your surgeon may want to use this material to ensure that the fusion actually occurs, which is all well and good, but there are some known complications with this. And the impetus for this video was a client of mine I recently had who had no clue that they used it in his fusion, didn't know what it was, and unfortunately he suffered some of the known complications from it, and now he's stuck with a major disability, having trouble working, can't play, can't do any of the things he loves to do, can barely go out to dinner. And it's a real sad story. So this video will focus on what the heck BMP is, and then I will put a link down below right after this one. I'm going to make his story, which we have some wonderful images. Thanks go out to him for letting us do this. That's very kind of him. All right, so I'm going to put my head down now and get to my PowerPoint presentation, and here we go. All right, recombinant human bone morphogenetic protein 2. That's a mouthful. That's why we often just call it BMP for short. So before we talk about this, now we should talk about what it's used for a little bit, just in case some of you have no clue what I'm even talking about at all. Interbody fusion, let's talk about that. And you can go, I'll put a link down to my website below. You can see it down here as well, chirogeek.com. I have a page under treatment category for fusion. So you should go read that if you have no clue and you're interested, or somebody said, hey, you need a fusion. So interbody fusion, it's a major spinal surgery for the treatment of chronic back and leg pain. And this is an end-of-the-road treatment. You don't ever have a fusion unless you've tried everything else, physical therapy, chiropractic, acupuncture, all of the medication, even everything. This is the end of the road because there's no turning back once you go in here. It destroys the motion segment. Sometimes it works great. Okay, there's our friend Tiger Woods. Okay, incredible story. That is a anterior lumbar interbody fusion story. For all you naysayers and haters on fusion that I see out there on YouTube land, here's a great example when it's almost miraculous, right? Three prior surgeries completely failed, and he has an ALIF. It's back to the days of old. As a caveat, if he ever watches this video, I think he's crazy for doing this, though. He should thank his lucky stars that he is able to function at such a high level, because I'm worried he's going to blow the disc out above or below, which is a known complication of interbody fusion. But you can read that on my webpage. I have videos on that as well. All right. So here in a nutshell, we know the spine. Now, if you don't know anything about spinal anatomy and how to read MRIs and things, go to back to my other YouTube videos on how to read your MRI, how to read your CAT scan, normal disc anatomy and spinal anatomy, because I'm going to assume you know a little bit here, okay? So this is a lateral view of a motion segment. A motion segment is a vertebral body of a segment above and a vertebral body of a segment below, and then we have a disc in between. And this is a cartoon that demonstrates what interbody fusion is. And what you do is you scrape out a lot of the disc material, not all of it, but a lot of it, and you slip some type of an interbody spacer. It's also called a cage. The cage is hollow, and you have to put some type of cement in here, because the goal of a fusion is to turn two movable segments into one block, which has no movement. Because some of the causes of chronic back pain, in fact, according to research, the number one cause of chronic back pain is a rip inside the disc, which I don't have shown in here just for simplicity. But if that disc becomes chronically painful and nothing else works on it, you can take it out of play by basically getting rid of it and substituting it for a cage, which will take all the weight bearing. But in order for this to accomplish, you just can't slide a cage in there. You have to fuse. You have to have a bony bridge that's bridging the superior and inferior vertebral bodies together. So you want to turn this into one block. This is the interbody part of the fusion. You also want to do some work on the backside because you want to fuse the facet joints. If you don't fuse the facet joints, they can become, or maybe they are, another source of chronic pain. So you need to take those out of play too. So this is the posterior component of that. So inside the cage, they're hollow, and you can pack a cement in there. It's not really a cement. It's really bone. The best substance is to take a bone from your hip and grind it up and make a paste out of it and then stuff it into this hollow cage. And then you can put some behind it. Good surgeons unlazy surgeons will put it in front, put it behind. You want to do everything in your power to ensure that this fuses. A lot of surgeons who are lazy, in my opinion, they just put it in the cage and don't worry about this. It's quicker surgery that way. But their rates of fusion are probably inferior to surgeons who take their time to really pack bone around the cage as well. Bottom line is, with the passage of time, 3 months, 6 months, maybe a year, maybe a year and a half at the longest, this is going to turn into hard bone. And so now you have a cage which is made of, you can use titanium, which isn't the best. There's something called polyether ether ketone, or PEEK, which is the best material. It's got the same Young's modulus as the bone, so it won't overpower the bone above and below. But you're gonna embed the cage in a case of bone. So that's a successful fusion. All right. So it seems simple, but it's not so simple because sometimes it doesn't work. Sometimes the cement doesn't dry. And so then we have the fusion complications. When the cement doesn't dry and it doesn't fuse into one segment, you got yourself something called a pseudoarthrosis. It's a dreaded, feared word because most of the time you're not going to have a very good clinical outcome with a failed fusion. It's a failed fusion. It's a failure to ossify. The rates with just straight iliac crest autograft, it's called. You take bone from your hip. It's iliac crest autograft. The failure rates can be as high as 35%. So that's not a great number. And so another problem with it, let's say it does work, but some people get harvest site pain where they take the bone out of your hip. It's really, they take it out of your iliac crest. And the rate of harvest site pain can be in about half of the people who have this type of surgery. There's a study here, a couple studies have shown that 2 years after the surgery, whether patients are doing good or not, they're still having some hip pain from this thing. So there's got to be a better way. So what's the fix? So spine surgeons needed something to increase the rate or the chances of fusion happening. And they developed something called recombinant human bone morphogenetic protein 2, or BMP we're calling it. So let's take a look at it. There's the AKAs. It was discovered way back in 1965 by Marshall Urist, and I'm not going to go crazy on here on its biochemical properties, but it's a protein, but it's a growth factor. It's a member of the transforming growth factor beta superfamily. So it has the ability to stimulate growth, especially of osteoblasts. And osteoblasts are what give rise to bone. They're little bone-producing machines. It was cloned and it's got closer to a more commercial use. Back in 1988, it was cloned and synthesized. We can make it now. It's no big deal anymore. And its job is to ensure that the target bones of fusion, in our case, the vertebrae on top and the vertebrae below, actually fuse together into one segment. So fantastic. More specifically, it doesn't do the job. It kind of stimulates something called stem cells, specifically mesenchymal stem cells. Stem cells can they're around in all bony tissue, all tissue of your body for that matter. But in bone, they're all over the place. They can turn into osteoclasts, which destroy bone, osteoprogenitor cells. There's all kinds of things they can do. But the BMP basically comes up to them, attaches to them, and then whispers in their ear, hey, you're going to become an osteoblast. And the MSC says, okay, I'll become an osteoblast. So bottom line is you get a whole bunch of osteoblasts form when normally you wouldn't have so many formed. And therefore, you got a whole bunch of these little bone factories, which is great because that's the goal of fusion is to create bone. So what could be better than creating a whole bunch of osteoblasts? So everything looks great so far on paper, right? And so it went through a bunch of pre-testing, as all new medications and drugs do, and everything looked great. In 2002, the FDA, the US FDA, said, okay, you can use BMP, spine surgeons, but there's going to be some guidelines. So you can only use it coming in from the front. So that's the Tiger Woods surgery. That's an A-lift. That's an anterior lumbar interbody fusion. So that's where they do the surgery, through the front. There's a general surgeon who comes in, pulls the peritoneum and the intestinal contents to the side, and then the surgeon comes in and works through the front to insert the cage. Okay, so that's one rule. These are called on-label uses, right? This is what the FDA says is safe. So you can do a single level. It has to be an ALEF. And the BMP, which comes in a liquid form, it has to be soaked into a special type of a sponge. And that's a type 1 collagen sponge. Medtronic is the patent holder on this, and they've called it the, what have they called it? It's just the type 1 collagen sponge. Here's what they've called it together, the sponge and the liquid together, mixed together. They've patented a name for that combination, which is approved. That's called infuse. And then, so this sponge in liquid, the liquid BMP, they have to be stuffed into a cage, right? Because it's got to get in that little cage like I showed you. So they're patented on that. That's called the LT cage. And then you insert the whole ball of wax into the anterior disc space. You carve a hole, basically get rid of a chunk of disc and stuff it in there. 2 of them. So let's take a look. Here's the LT cage. This is Medtronic's. And here is a soaking wet sponge that is filled with a BMP. The osteoblasts, in order to form bone, they have to have something to work. They just have to have something to attach to. So they attach to the microfiber in this sponge, and then they produce bone there. They have to have a scaffolding to work. All right, so this goes inside the disc space like this. Here's an overhead view of anterior or an ALEF procedure, anterior lumbar interbody fusion, and they stuff 2 cages in there, and great. The BMP I didn't leave in there, but you can see it here, and that's what it looks like. View from the side. Okay, so they're tapered because they want to encourage the lordosis of the lumbar spine. So it's a pretty good design. Remember, this is the Tiger Wood type surgery, although I'm sure they didn't use these cages are kind of, I don't want to say they're obsolete, but there's a lot of different types of cages you can use. And then once you have it in there, you can put a metal plate over the front of it. It's like a cast to give it a little strength while the bone forming process occurs. You can also go around to the back side and put pedicle screws and rods in to give it extra strength, and you can fuse the back. That's called the 360 fusion, which is great. Okay, here's a different type of cage, but this is an ALEF procedure. This one, there's no metal plate on the front, but they do have screws going into the bone to hold the cage in place. And has a fusion occurred? My students, who are getting pretty good at some of this stuff, has this fused yet? No, this is not. This is a fresh surgery, right? Because the cage is hollow. If this was a successful fusion, or maybe it's an old case that it failed to fuse. I don't know. But this is not, if it was bone, it would be the same color as the bone. So this is not fused yet. But there's lots of different cages that point to that study. So great. So who follows the rules? Off-label use of BMP went wild as soon as the FDA gave it its approval. And based on two things. Let's look at some of the results of the industry-sponsored studies, which, by the way, the industry-sponsored doctors who conducted these studies got paid millions and millions of dollars. So that always raises an eyebrow, right? When the manufacturer is paying you big-time money, sometimes the results tend to favor the manufacturer. There's studies on that. So, and that's what happened. So the early industry sponsored investigations showed remarkable rates of fusion, going from the mid 80% up to 100% fusion. That really got surgeons excited. And some of them were in the 90%, so high 90s. And that's true. I've been involved in BMP research work and seen data with my own eyes, and I've seen a 98% success rate. There's no question in my mind, or based on the research out there, there's no question that this stuff works. But we'll get into the complications. The other icing on the cake was there were no complications reported in any of the early studies. I mean, wow, how good can that be? There's nothing can go wrong. The surgeon has nothing to lose and everything to gain. Great, let's put it into our patients. And that's what happened. So it stimulated off-label use. Remember, it's only supposed to be used for A-lift. Now it's being used in T-lift, P-lift, X-lift, PLF, all the different types of surgeries is now using it. Somebody investigated the increase in BMP usage in about a 6-year period of time. One study found a 500% increase in the use of BMP. Medtronic is just making a killing, right? Medtronic stock's going through the ceiling. Everything is great. But the party is about to end based on some work by Eugene Carnegie of Stanford. He's the head of orthopedic surgeon. Famous authors published some great studies. So let's look at some. He reviewed all that data that came out originally, and he didn't quite see the same thing the original industry-sponsored trials saw. So, and it wasn't just him. Pretty soon, spine surgeons love to do research, right? Pretty soon reports started coming in of all sorts of complications. Dysphagia, trouble swallowing. They went in there and there's this weird inflammation for people who had ACDF, surgery around the cervical spine. Tons of reports of that, right? These are all papers. All of these are papers. Seromas and hematoma formation went way statistically increased. I mean, it's normal to get hematoma formation sometimes and seroma formations, but they're going off the chart. And then this weird osteolysis. So I'm not going to get into to talk about the biology of fusion. I think I have a video on that though somewhere. But before bone can grow, there's actually an inflammatory process that occurs, and it can be a little destructive. That in fact, that's why if you've had a fusion, you don't take any anti-inflammatories ever. You'll decrease the chances of it working because there is an inflammation that occurs. But this is not very common usually. I'll show you a picture of this in a minute. But with BMP, we're getting huge chunks eaten out of the bone, the superior and inferior inf plates, following the procedure. Usually it didn't matter because following this osteolysis phase is the osteoblastic phase, and it usually filled in. Hopefully the cage didn't sink in too much from the osteolysis. But then the problem, and kind of the star of this video, is the formation of bone where it shouldn't be. There's so many osteoblasts that they're making bone inside the cage, inside the disc space, great, but they can leak out of the fusion. The annulotomy, which is used to put the cage in, I got a nice cartoon of that, I'll show you. But it can leak out, and now you can start getting bone formed outside, almost like a disc herniation of bone. And sometimes it can take the epidural space over on that side, and it could look horrible. And unfortunately, in my poor client, I'm calling him Tom, that's exactly what happened. He's like, what the heck? No one warned me about this. Nobody told me about this. How can this happen? And it can be devastating because it can entangle the nerve root, and it's really tough to get out. Most surgeons won't touch it. So we'll look at that case. I'll put a link down below. A very interesting case. You're not going to see that very often. I think it's definitely the only one on YouTube, and there's not even many papers on it. So that's a case of heterotopic bone formation as a complication of the use of recombinant human bone morphogenetic protein. Then there's this weird unexplained radicular pain. So patients who had BMP were getting, maybe their back pain was better, but now they got a really weird, strange, horrible leg pain, burniness, sciatica, and a new MRI would be performed after the surgery, and there's nothing there. There was nothing compressing the nerve. Like, what the heck? How can that be? So it's got to be something to do with the BMP soaking in the nerve root. We still haven't figured this one out. And then came the C word, cancer. This is where Carnegie came in. Carnegie recrunched the numbers, and he shocked the spine research world by saying, not only are there's complications from BMP, but I've detected an increased chance for cancer. And everybody freaked out. The lawyers, you saw the ads all over the internet. If you've used BMP, contact our law office. And money may be owed to you. You may have been damaged. Those were going wild for a while. So Carnegie sparked this huge cancer scare. And here's you can go to my website again. I got the exact research published there. But the early studies did use very high doses of BMP. We don't use those high. They're using 40, 50, 60, 80 milligrams of this stuff. Today we use 10 milligrams. So maybe there was something to this. But other authors weren't so sure after the work of Carnegie. So the sky is falling. The use of BMP probably dropped by 450% after those studies came out. So everybody was scared, and they're still scared to use it. But then other authors came out and said, let's wait a minute here. I don't see a risk of cancer. Simon's 2013 is one in particular who started the bandwagon. Kelly did a pretty good-sized study, actually a huge study, with 46,000 BMP patients. And he half of them, it's not exactly half. The study's on my research page on my website down here at chirogeek.com. But a huge study. About half of them had BMP used during their fusion, and half of them didn't use BMP. And they basically followed them, I think it was 5 to 7 years, to see, are they going to get cancer or not? They compared the two groups. And they didn't get cancer. In fact, the group that used the BMP actually developed less cancer than the group who didn't use the BMP. So now is BMP a cancer cure? So you can see everybody's confused. But this is this is a big study. So that was enough for me. I feel confident as long as the patients understand that there could be a chance that we haven't seen yet. I'm okay with using it. I don't have a problem with clients using, especially high-risk smokers and osteoporotic patients. I'm pretty confident with the research. But again, research is research. It can always be shown wrong, so there's always that little smoke in the background. This is a study I just actually pulled up last night, 2017. Another good-sized study from Baldus. 593 patients had BMP. Very high doses. This is what's unusual about this. We usually use 10 milligrams, right? These were scoliosis patients, and they used big doses of BMP, on average over 40 milligrams, so that's quite a bit. And they followed them for 5 years. At the end of this study, there was no chance, there's no increased risk for cancer development at all. So based on a couple of studies, I think it's pretty safe to say that was kind of a henny penny, the sky's falling down type of thing. It looks to be pretty safe. I'll keep an eye on it, check my research page, and I'll my kind of geeky, hey, Chiro Geek, right? I keep an eye on this stuff, and if anything developments break, I'll post it on my website. All right, so that checks off cancer, I think we can kind of not worry about that so much. But what about the other complications? Can we check those off? We can't check those off. Those are real, and that's just part of the risk of using BMP. There was a systematic review, which is one of the highest. A meta-analysis is a little bit more powerful, but this is powerful. It's a study of all the high-quality studies, and it found that the risk of complications, that list I presented, excluding cancer, was about 30 times higher than what the original industry-sponsored surgeons put forth. 50. Some of the studies were up to 50%. So that does not bode well for the industry or the industry sponsored. It really was a black eye on all of these. I won't go into their names, but it was, I won't say any more. You can read between the lines. But in the systematic review, they even said that these industry-sponsored surgeons receive tens of millions of dollars for funding for these and fees for doing these studies. So I will say no more. There are complications. Osteolysis, I kind of described it. Let's take a look at it here. So this is that lateral view again. We can see a normal bone here. There's the vertebral body. My first quarter students should be able to understand this, right? We talk about these images a lot. Here's the articular pillar, inferior articular process, superior articular process, pars intraarticularis. This is the hole, the intervertebral foramen, inferior end plate. Should be straight, right? It should be like a square type block. It has to take a lot of pressure. Let's look at this patient who had BMP used. What do you see? We see a huge hole, like somebody took a bite out of the vertebral body. That's osteolysis, one of the known complications of the use of BMP. In fact, Tom also had a bit of osteolysis, but that wasn't the main problem in Tom. He had the heterotopic bone as well. This guy didn't develop any heterotopic bone, but he developed some wicked osteolysis. The cages shifted out of place a little, and they had to redo this surgery. All right, that's a pedicle screw coming through, if anybody's wondering. So that's osteolysis. What about heterotopic bone? This is leading up to our patient study. So heterotopic bone. Now with anterior lumbar interbody fusion, since they come in from the front, we don't have to worry as much, right? Because if it forms out the front, there's really no nervous structures out there of major importance with regard to pain. But since everybody's doing it off-label from the posterior, you could exposing the nerves to BMP. And what happens is you get an epidural leakage of the BMP out into the vertebral canal, into the epidural space. It soaks into the thecal sac, soaks into the spinal cord if you're using it in the cervical thoracic spine. And it does its thing. It turns to bone, and the nerve roots can become snared and entangled in bone. Scar tissue is bad enough to deal with, but bone is like ridiculous. Most surgeons won't get involved in a case of heterotopic bone, a radiculitis caused by heterotopic bone. So not a good thing. And it can cause, as the case of Tom, it caused a new radicular pain, and he still got it. The only course now is a spinal cord stimulator, which, that's another YouTube video. Sometimes it works, sometimes it doesn't work so good. There's problems with those. So here's my little cartoon drawing. So when he had a PLIF study. So this is an overhead view. Here's the facets. The back is here. Your belly would be over here. Here's the sinovertebral nerves, only drawn on one side, so I save some space over here. These are the pain carriers, right? The disc. If you get a rip through the disc and irritate these, you could have yourself some severe chronic back pain. You have your exiting nerve roots here. These are the traversing nerve roots. These can be, if this is L4, this is the L4 exiting nerve root. This is the L5 traversing nerve root. Okay. If you're lost, go to my anatomy lessons and you can get up to speed. When they do a TLIF surgery, they destroy this facet joint. They take the bone, they grind it up. They mix BMP in with, there's different ways to do it. They can mix the BMP in to this mashed up bone for like a BMP bone paste. The surgeon with Tom actually still used the sponge and stuck the sponge inside the cage like he was supposed to, or that's at least what he said he did. And so they do an annulotomy after they destroy the facet joint. You got the disc staring in the face. Remember, you got a traverse or an exiting nerve root here. You got to retract that out of the way to make some room. And then you cut a hole in the annulus. Here's your cage packed with BMP. You slide the cage in. This is kind of how it sits. You try to get it in posterior or in T-lift fusion. This, you just use a single cage instead of a double cage. Try to get it as far forward as possible. And that's it. Then you put pedicle screws and rods in the backside and you wait. And the BMP takes 4 to 6 months, which is really fast, to generate new bone, which is great, as long as the new bone stays here. Maybe the surgeon was a little sloppy. Maybe he put too much BMP in. The sponge was dripping with BMP. As he slid it in, it kind of left a trail of BMP. And then that trail, after they closed up the surgery, the trail kind of leaked out the back. So we don't know why. We don't know. It's got to be something, though, because not everybody develops this, what's going to be bone. So now we got BMP floating around in the epidural space, and that's not good because in 4 months, 6 months, it's going to do its thing and turn to bone. And now we got a horrible, horrible mess because the nerve root has been encased in bone in this case. I did a kind of a weird one here. This is out of the epidural space. This one's in. I was just showing differences, how you can present. But in this case, this is the traversing. If this is L4, this is the L5 nerve root. It can also get the exiting nerve root. I just didn't draw it in. But the bottom line is we got crazy bone in the epidural space. That's terrible, right? What are you going to do? How are you going to fix that? You can't fix it. Well, some surgeons dare, and when you talk about the story of Tom, I'll show you a group who dares to take this on, and it can be decompressed, but I'll save the story of Tom for the story of Tom. All right? So that's heterotopic bone formation. That's about everything you need to know. You can, again, go to my research page. I have more information on this if you need to know more, but that's pretty much it. All right, so thanks for hanging in there and watching this. And I'll put a link again down below. You can see the story of Tom and his 4 failed fusion. It's really interesting because it's not all about heterotopic bone. He had a fracture. One surgeon broke his inferior articular process off. It's just a recurrent herniation. It's just a nightmare story. All right, so we'll see you in the next video. Thanks for watching. Oh, one more thing. Let me just mention, some of you are wondering how to contact me. You can contact me at chirogeek.com and send me an email. I do online consults. I call it a coaching service where you can send me your MRI, CT, discography, whatever you got. We can use GoToMeeting. I can share my computer screen with you. We can go over your images step or slice by slice and really look at them with a microscope. Radiologists go over them in about 8 minutes. You can buy up to 90 minutes of time, which many clients do, and we can really try to ferret out what's going on. You can read my testimonials and see I've caught a lot of stuff that radiologists have completely missed. All right, so we'll look forward to seeing you in the next video.